off to join us this evening. So as we all read from the announcement, we just dubbed tonight's discussion as like Ask a Pharmacist. Basically, so let me just give like a brief overview of what we're going to do. We want to discuss like three major topics, and then we'll open the floor up for discussion, which is not, or for questions and answers, which is not necessarily based on what we've discussed or what we're going to discuss, but any question that you have on your mind as far as like pharmacy is concerned, please feel free to bring it up. We have a group of licensed pharmacists on the panel tonight, actually great experts in their field, and they're ready to pretty much field all your questions. I mean, if there's anything that you have on your mind as far as your medications or like pharmacy is concerned, please feel free, ask us. And if it's something that's private or personal and you wanna reach out to us offline too, that's fine. But basically, we want to offer the opportunity for everybody to be able to have their questions answered. But so just a brief overview of what we're going to talk about. First, we'll be talking about brand name, generic names. I'm pretty sure if you've used a pharmacy before or you are on any type of medications, you're probably familiar with those terms. So we'll go ahead, define those, and then pretty much tell you what it means or how, like, why you should even care about things like that. Just before I proceed on the general topics, though, I want to introduce the pharmacists who are going to be on the panel. And if you're a pharmacist on the call right now and I fail to mention your name, please let me know so I can recognize you. And like I said, it's a group of Santa Clausian pharmacists. So especially when it gets to the question and answer session, if you want to jump in, you're a pharmacist, you are more than welcome to jump in. I mean, this is one of the things where too many cooks won't spoil the broth. So please feel free to jump in when it gets to that session. But tonight we're actually honored to have in our midst, so far, let me see, Dr. Kofi Boydou-Ansah and Dr. let me see, Kwame Boateng. He's my senior from Cantab. So, and of course, a CBO from his days on the Hill. Senior Kofi Boydou-Ansah, I'm sure most of you are already familiar with him. Co-president of Aoba North America and also a deputy head prefect when he was on the Hill. I think I see another senior here, Senior Alex Omwa. If I'm not mistaken, you're a pharmacist as well too, right? Right.
Yeah, yes.
So, okay. All right. So thank you for joining the call and welcome. And I hope we can use some of your insight tonight as well. So like I said, if there's any pharmacist on the call that I haven't recognized, please give me a shout out, raise your hand or something, just get my attention so I can recognize you as well.
Leo, I think you're muted.
Thank you. Okay. All right. So like I said, we're going to talk about like brand name, generic names, and that particular subject, let me confess, was requested by our one and only senior KS, Senior Kwabena Sapon. I mean, he wanted us to talk about it because he felt it would help a lot of people, and I completely agree. Because, I mean, you go to a pharmacy to pick up your medication, they throw these things out there, and it's like, okay, what are they talking about? Are they the same thing? Is it safe? And that kind of stuff. I know all of us at one point in time, even if we are not on any medication for maintenance, if it's not something we do on a daily basis, at least every now and then, especially with this flu season coming in, with COVID still hanging around and all that stuff, unfortunately have to use a pharmacy at some point. So these are things that I guess pertain to everybody. And if we know some of these things will help us. And then when we're done talking about the brands and generics and stuff like that, we will also talk about some pharmacy, I guess, money-saving tips, how to make the most or to get the most bang out of your buck. So we'll talk about that. And then finally, we will wrap it up by talking about why it's essential or why it's advantageous to, have a relationship with a pharmacist or use the pharmacy resource that you have available. I mean, that's one of the medical resources or the health resources that we have that's, in essence, like absolutely free. You can pretty much walk to any community pharmacist and ask to talk to the pharmacist, and they will gladly talk to you, answer your questions, and you don't have to pay for it, unlike when you have to go to your doctor's office and all that stuff. And, most of the time, even if they don't have the answers, they can point you in the right direction. So we'll discuss that, and then after that, we'll open the floor for questions. So with that said, what I would go ahead, I would start with the brand and generic, and then after that, we'll get Senior KB to give us a few pointers on the money-saving tips and also like stuff we need to know to be able to save some money on our medication and things like that, and then we'll go from there. So when we hear a brand name medication, oh, this medication is brand, like you go to pick up a prescription and the pharmacist tells you it's so much or it's not covered by your insurance because it's brand name, or your doctor writes a prescription or tells you this is the name of the medicine, and then you go there and the pharmacist tells you a different name but tells you it's the same thing. Like, what does that mean? So brand name, technically, when we say brand name, we're talking about the medication as originally made. So in the drug discovery process, when they first discovered the compound or the chemical that they're going to use to make the drug, the company, let me use Pfizer as an example. So when Pfizer comes up with a drug, they give it a name. That becomes the brand name of that drug. And usually, because of the steps that they have to go through just to get the medication approved, the Food and Drug Administration, which is the agency that regulates the use of medications or prescription drugs, allows them, or the government gives them some time to recover all the investment that they made in the discovery process or in the marketing and all that stuff. Basically, they allowed them the opportunity to reap some of their money, including, the investment and profit. So when they discover it, of course, it's patented. And while the patent still exists, nobody can manufacture the drug. So when you hear brand name, and I'll give you an example, a very common example, I guess, if you will, Lipitor. So once that medication was manufactured, the manufacturers gave it that name, and that's the only thing you could buy if you wanted that medication. So you go to any pharmacy, your doctor prescribes that medication, that's all you get. Nobody is allowed to manufacture that drug in any other form. So until that period that they have legally expires, nobody is allowed to make that medication. If you want it, then that's all you get. You're just stuck with that manufacturer. So when you hear brand name, that's what it means. Insurance, different insurance plans, different insurance plans handle them differently. Sometimes you hear my insurance doesn't cover this brand, or my insurance doesn't cover that. Basically, that's all that it means. So the medication as originally manufactured by that particular manufacturer is the brand name. Now, usually that would last, let's say, about 10 years or whatever, depending on many circumstances that they use to determine the exclusivity and the patent life of that drug. Once that expires, they open it up for other manufacturers who want to jump in to manufacture the same medication. So at some point, and that's where we come to that whole concept of generic medication. Basically, at that time, the FDA gives other manufacturers the permission to manufacture a brand name medication, but I mean, they usually use what they call the generic name, which is technically the scientific name of the medication when it's discovered. So for people who are on medication, I mean, you can pick any medication that you want. You would usually, when you pick it up from the pharmacy, the label would say the brand name, and then also in parentheses, you see another, like you could tell it looks more like a scientific name. Usually it's the more difficult one to pronounce. Or it would have some salt from like sulfate or oxalate or something like that in addition to it. So that's the generic name. But basically, it's the same medication. Now, for a medication to be approved as a generic, the active ingredient, which is basically the chemical in the drug that's actually healing you or solving whatever problem that needs to be solved, the active ingredient that actually does the trick, that part of the drug has to be exactly the same as the brand name medication. I mean, basically, that's the most important part of the medication. And for you to win the approval from the FDA to manufacture any medication as a generic alternative, it has to meet the same standards. The dosage form, the effectiveness, the dose itself, everything has to be exactly the same. And they have other standards that they use just to make sure that it meets their level, their system that they've set in place. And once it meets their approval standards, they approve it, and that generic drug company is allowed to produce that medication. Now, so once that starts, I mean, usually you have more than one company producing the same generic medication. You have, and especially with some of the stuff that's going on, you have people coming to the pharmacy asking you, is this drug coming from India? Is this drug coming from China, Canada, whatever? But basically, it's because the FDA has given them permission. And regardless of where it's coming from, it has to meet their standard. I would just use that as I guess, a segue to talk about its safety. Because of that, it meets their standard of safety. If that brand medication is good enough that it's not going to kill you, then when you take the generic medication, it's not going to kill you. However, there are certain differences. I mean, sometimes the fillers that they use to make the drug. So when you take something like a tablet, it's not just the active ingredient. For it to be stable, they have to put it in a form that you can actually take. So when you take a tablet, for instance, it has the white powder that you actually see. Sometimes it has a coating on it to protect the drug till it gets into your intestines where it will be absorbed for it to be released, and all kinds of stuff. When it comes to the fillers and the other, what we call inactive ingredients that they use to manufacture the medications, they also have to meet certain standards, but they don't necessarily have to be the same thing as long as they meet the standards. So that's, in effect, the difference between brand name and generic names. So in general, it's okay to switch brand names and generic medications. One of the main points, or why it's even important for us to talk about this, is all about pricing. We all know if the doctor prescribes a medication for you and you can't afford it, it's pretty much useless because you won't be able to take it. Now, with the same medication, if there are generic alternatives, they tend to be cheaper because they don't have to go through the same animal and clinical testing that the original manufacturer had to go through when they started their process. So they tend to be much, much, much cheaper. So I guess this is where I'll offer my personal advice as a pharmacist. If you have the opportunity to use a generic medication, I say go ahead and use it. I mean, that's what I do for myself and do for my family. It's pretty much the same thing. They're just as effective. They're just as safe. There are a few medications that doctors are really not comfortable switching between, like brand and generics, mostly because for whatever reason, they see certain differences in how people respond to them. I'll give you a quick example. If you are familiar with the anticoagulant warfarin, they usually call it a blood thinner, Coumadin or warfarin. It's one medication that a lot of doctors would tell you they don't like to switch generics. That doesn't mean that the generic is bad, because especially for that medication, I'm not even sure you can find the brand name on the market because it's a very old drug. It's been out for so long, it's all generics. But basically, they want you to stick to one generic when you start on that, because when you do your blood work, they tend to see some kind of like difference in your blood work or your INR when they check it. There's another class of medications, thyroid medicines, Synthroid to be exact, that a lot of doctors don't also like, at least based on my practice and experience, don't like people switching between brands, because when they check your thyroid levels, sometimes there are slight differences, and because of that, they don't recommend, or they don't usually get excited when you switch patients back and forth between different brands. But other than that, like I said, for the most part, if they prescribe a generic medication for you, or if they prescribe a medication for you and there is a generic alternative, it's actually better to go for that, because it's the same medication. It's just as safe, just as effective, and most of the time it's cheaper. So I don't want to keep going on and on. I'll just, I guess, hand it over to Senior KB at this time, Dr. Kwame Boateng, to take over and talk about some of the ways we can save money when it comes to prescription medicines.
Oh, thank you. So, like Leo was saying, one of the things that he did mention, he talked about generic medications. It's one of the number one ways to save money when it comes to prescription drugs. But I'll start from the top. Usually what I would ask is, or what you want to ask yourself is, do I really need this medication? Because there are different kinds of medications for different things. You would find that we have medications that are used for purely cosmetic purposes. Those tend not to be covered by insurance and tend also to have higher copays. So that's the one thing that you want to consider. So do you really need it? And also, it might be that it's something that you've been given by your doctor to take. You've been on it for a year, a couple of years. You've probably done certain things to improve your lifestyle. Maybe it was something that they put you on, say maybe a diabetic medication or blood pressure medication, but you've done some things. You've improved your lifestyle, you are exercising, you are better now. You probably need to go off some of these medications. It's a conversation you can have with your doctor. To do that, make sure you have regular checkups. Decide not to go, but make sure you get regular checkups. They do all the lab work, make sure everything is fine. They can cut you back on some of them and say, instead of taking maybe 2 or 3 diabetic medications, you can take only 1. Okay, so we've talked about generics, we've talked about that, whether you need the medication. The other thing too is to consider a different type of drug altogether. So they might put you on a name brand medication that does not have a generic. But then there might be alternatives that can work the same way and achieve similar results, might work differently, achieve similar results, and in the long term will be cheaper. Now, there are 2 things that come into play when it comes to prescription drug prices at the pharmacy, at the point of sale. Whether you have insurance or you do not have insurance. Because the prices that the pharmacy will quote you if you do not have insurance is higher than what they quote your insurance, because the price that your insurance pays for that same medication or the insurance will pay, it's kind of like a contract price. So it's not the same thing. What you would see at a pharmacy is not what an insurance company would see or reimburse the pharmacy for that product. So if you do not have insurance, then you want to, there are a lot of things that you want to consider. You want to look for discount cards. Good RX is not the big thing. They have commercials all over the place, but there are more like them. It's not just Good RX. So that's one to look at. And it also gives you the option to actually shop pharmacies. So when you pull up a Good RX app or coupon, it will tell you what each pharmacy will charge you if you were to show up at that pharmacy. So you can do your, kind of like pharmacy shopping at that point and decide, well, I'm gonna go with the Rite Aid or go with the Walgreens or with the Walmart or a Costco. Now, some pharmacies also have discounted products right from the get-go. Costco tends to have very good prices. And I don't think you have to, Costco and Sam's Club, these they have this kind of warehouse pricing, but I don't think you have to be members to use their pharmacy. So you can always walk in there, use their pharmacy, you would save money. Walmart also has their generic pricing, which changes from time to time. These are the companies that I know have discount pricing. So that's something to consider. And then also, the drug manufacturers also have prescription assistant programs. So I always tell, when people come to the pharmacy and they get that sticker shock, where the product is like maybe $100, $150, and they go, but I have insurance. I say, I understand, but that's a $5,000 drug. That's your portion of it, but you can actually go to the manufacturer's website. A lot of times they have patient assistance programs where if you qualify, and usually most people qualify, unless you're on some kind of government assisted program, then you probably will not qualify. But most people qualify where they will probably take up your copay or a greater percentage of the copay over a 12-month period. There are instances where they would give you your first fill for free, actually. So that can also save you some money. So that's one way to look at it. If you don't have insurance, consider the Good RX or the other coupons out there. Even if you have insurance, but your copays are not the best, because depending on the kind of insurance you have, you might probably have high copays for certain medications. And then also, if you have insurance, you need to consider one other thing, whether your insurance allows you to go to certain places or allows you to go everywhere. So they have what they call in-network and then out-of-network pharmacies. In an in-network pharmacy, of course, you'd have lower copays. Out-of-network pharmacy, then they hit you with premium for using that facility. And then my recommendation, if you have insurance, try sign up for an FSA or HSA plan. That way, you are actually paying for it, but it's not coming out of your pocket directly. So you don't really feel the pinch, and it's kind of like savings for you, not savings really, but savings for you one or the other. Because then that money is, the FSA money is not going to come to the end of the year anyway. So you can use that at the pharmacy to pay for your co-pays depending on what it is. Now, depending on where you live too, because I lived in the Charlotte area for a while, and in that kind of big urban setting, they have county clinics that are funded by the county with tax dollars, where if you don't have insurance, you can show up, they'll take care of you. They have kind of sliding scale payment plans where you would have maybe like a $20 copay, and prescriptions are really cheap for you. That's also something to consider. So if you live in an area where that is available, you can speak to them. Of course, you need to qualify before you can use that facility. The other thing also is to consider a 90-day supply versus a 30-day supply. Because again, the more you buy, the cheaper it gets. So if it's something that you're on some maintenance medication, you want to look at that as well and say, will it benefit me if I, get a 90-day prescription versus a 30-day prescription? Of course, the savings there, it's more than onefold. You save on gas, you save on your time, which is one of the things that we normally don't cost. The time that you spend running back and forth from the pharmacy every 30 days, plus in making that bulk purchase, you'd also save some money. Of course, you also have to consider that you'll be paying almost 2.5 times the amount you'd have paid. That initial outlay, if you can afford it, that's something to think about. Um, I think those are the points that I wrote down for now. As it keeps coming to mind, I'll bring them up. But that's what I have for right now.
All right, thank you, Dr. Boateng. So, like I said, now that we've talked about the money saving tips, we'll go to Dr. Kofi Buedo Ansa to pretty much wrap it up with why it's important for you to take advantage of the free pharmacy resource that you have to improve your health and that of your family. So please take it away, Head Pro.
Thank you, Leo and Katie for the excellent presentation. And as you heard from my esteemed colleagues, you've heard about generics and why it's okay to take generic drugs in the event that there's nothing precluding you from taking a generic drug. And then Kwame also went ahead and shared some cost-saving tips with us. I want to end the presentation by entreating everyone to make use of the pharmacists at the pharmacies in our neighborhoods. So when you talk about healthcare accessibility, that's one avenue where they are readily available to us. So let's use our pharmacists. And most of the time when it comes to it, the pharmacists know more about the drugs and what they do than most of the physicians, right? Not that the physician know what they prescribe in it for you, but the pharmacist can give you an ins and outs of the drug. So let's utilize that. One big area where you can utilize the pharmacist is in these days, most pharmacies have give flu shots. You can get vaccinations in the pharmacies. And so build that rapport with them and get those care there. And then you can approach them with any questions that you have. In my practice, I'm no longer in community practice, but during my time in community practice, my patients came to me for almost everything. They'll ask you the questions. Granted that sometimes you may have to call ahead of time or wait a little bit for the pharmacist to get to you because, again, they are being judged by their bosses by how quickly they are filling prescriptions and getting people out. And sometimes there is not much help. So if you choose or if you want to utilize them, I will encourage you to give them a call ahead of time and set up a time with them to come in. Or if you go in and you have to wait, just understand why you are waiting. It's not because they are blowing you up. Because sometimes that may be seen by customers as the pharmacist not being approachable or not wanting to help you. But I'm trying to get you to understand that there's so much that goes on there. He has to make sure he puts what he's doing in the right place so that he doesn't give somebody the wrong medication before he steps away. So just give them a little time back. Utilize these resources that are available to us. One thing too that pharmacists can do for you, and that we do mostly these days, is something called medication therapy, medication management therapy. So as I believe it was KB who mentioned that in his talk, that they may have put you on a medication a year or so ago. You've engaged in some lifestyle modifications, and perhaps your blood pressure or diabetes or whatever it was is now a bit controlled. Do you need all the 3 medications or 4 medications that you were initially put on? This is where you can also, engage the pharmacist, talk to them, and they can assess and perhaps engage your physician or your primary care provider to tailor your medication down based on where you are currently are. So there isn't much more to add to this, but if I will digress a little bit and jump on my soapbox that we, particularly as men, are a little hesitant to go seek help or go to the doctor's office or go to the physician, but let's try and at the least get our annual physical checks. It's very important, and I'm talking from experience. It's very important. When something doesn't feel good, 99% of the time there is something wrong. Just seek that help. It's easy to control some of these ailments or get them under control when they diagnosed early or they are caught early. So that's my ending bit in there, that let us all endeavor to find so some of the techniques you can use to, some of us forget, some of us don't like to do that, but try to schedule your annual physicals maybe around your birthdays, right? Because your birthday comes every year and it's easy for you to remember, or around an anniversary, or around the new year, whatever works for you, whatever will help you to remember to engage in these live, very critical live changing practices that will see us all living to see our grandkids, God willing. So that is my tidbit that I wanted to add to that. So Leo, I'll toss it to you, and I guess at this point we can field questions if anyone has questions, particular questions that they want us to address for them. And thank you for the opportunity.
All right, thank you very much. So for those of you who just joined the call, we've been talking about pharmacy this evening. Thank you so much, Senior KB, for the excellent presentation. And there are some of the things you talked about that actually didn't even cross my mind. But I mean, basically, these are some of the ways you save money on your prescriptions. I mean, knowing what your plan really pays for, where, I mean, they would pay for, where their preference, like what their preferences are, like whether they want mail order, well, whether they want you to get a 90-day or 30-day, things like that. Just the very important details in your own plan and all the great stuff you talked about. So at this time, I guess we'll open the floor up for questions. Actually, you know, before I do that, Dr. Somoa, I want to give you the floor to just add, if you want to add something to what we've presented tonight, before we open up for questions, and then we'll go from there. Okay, I guess we must have lost him. So, like I said, we'll open up for questions, and not just restricted to what we've discussed so far, but any pharmacy question that comes to mind, please feel free and just bring it up, and then we'll go ahead and try to address it.
I have a couple of questions, but I'll put them out one at a time.
Okay.
Does the FDA watch the production of generic as closely as they watch the production of brand names?
I'm sorry, I think I missed some part of your question. Can you, is it possible to repeat that?
Sure. Does the FDA watch the production of generic drugs as closely as they do with the brand names?
Okay. So, Hepwood, you want to take that since that's your, or you want me, I can answer that.
I'm sorry, Leo, I didn't hear what you said.
Okay, so the question was, does the FDA...
No, I had a question. I didn't hear what you said.
Oh, okay. I'm sorry. I wanted to know if you wanted to jump in and answer that, since that was your area of expertise, and then we'll...
Yes. To the short answer to Niasari's question is yes, they do. They have the same. They have standards, set of standards for bringing a brand medication to market, and they have a set of standards for bringing generic medication to market. And as Leo alluded to in his presentation, these are very stringent criteria that the FDA goes through to approve a generic product. And because of competition, you be rest assured that another generic manufacturer can get your product and go and test it to make sure that it does meet the standard. And if it doesn't, they will file a lawsuit against yourself and the FDA. So the short answer to your question is that yes, they go through the same stringent criteria and regulatory due diligence making sure that all these products, be it brand medication or generic medication, have gone through the requisite regulatory guideline standards before coming to market.
I'll hold off on my other questions, but a quick follow-up is for the pharmacist: if a generic drug and the brand name drug are both available and cost the same, or your insurance is paying 100% for either without question, as a pharmacist, which one would you prefer to take?
So what I would say is that you see, the truth of the matter is every pharmacy is in business to make money, and it's the money that drives whatever we do. No matter how we would, sugarcoat it and say, there are other things like we care about people, we want, the best for everybody else. But the bottom line, which is unspoken, or the big elephant in the room, is money. Money for the investors, money for the employees, money for everybody. And for the brand name medications, the pharmacy does not make money on them. The profit is actually on the generics. So the drive to push the generic, one of the underlying reasons is the cost of it. Because the cost is not to you, the individual alone. It's a cost to whoever has insured you. So it's a cost to the general healthcare system, it's a cost to your company because they pay for your insurance. So that drive to give you the generic will save you money, will save your company money, will save your insurance company money. It kind of snowballs, but the truth of the matter is, for the way I understand it, it's the money that drives everything. And there's more money to be made on a generic product for a pharmacy than a brand name product. So
yeah, that's why I said that, assuming that cost is not a factor, my insurance will pay whether generic or brand name. So I don't care. And I take the phone and I call you, doc. I have this year, they cost the same. I'm not the one paying for them, though I pay my premium. But which one do you think I should take? They are the same price. And the pharmacist says I can take any one that I like. Which one would you recommend that I take, the brand name or the generic? Cost is not a factor.
See, and that's what I'm saying, that for you, it's going to be a zero copay. So for you personally, there's no cost for you. But for everybody else, there's a cost to it. Now, for me as a pharmacist, to sell the product to you, normally I would recommend a generic. Reason is, if I put it on the scale, on the balance, and they're both going to do the same thing and will work the same way, then the next thing that I'm going to consider is, what am I going to get out of it, because I need to make a living. That's
okay, let me restructure my question again. If they are giving to me as for free,
right?
For free, which one, if I call my friend pharmacist and ask, this is the situation, it's being offered to me for free, but I can't take both.
Okay. So
I would tell you to go for the name brand.
Okay.
And I'll jump in here, KB. I will tell you, I will leave it up to you, the patient. In this particular case, as KB stated, rarely is the generic and the brand name the same price, rarely. But in this particular case, and by the example you are giving, is the same price. So I will give it up to you. But what I will advise you as a pharmacist, and looking down the line, is, as KB said, everybody in that healthcare chain, from the doctor's office to the pharmaceutical company, is in to make money. Yes, we want to make people to get better, but at the end of it, R&D costs money, right? So that brand manufacturer, as more and more generic come to the market, it's not going to be lucrative for them to continue making the brand medication anymore. So it's conceivable that at some point they may stop manufacturing that brand medication. And then what do you do at that time? So in my case, I will, as KB said, for my bottom line, I would prefer you took the generic. Also looking forward along the line, because this is happening now. There are sometimes you see drug shortages and that medications are not available. So I will advise you, I will give you the information and then let you make the decision. The choice is yours. So that's how I will approach it, if you were to ask me that.
Okay.
This is David. Back to the question that Senior Sari asked. So if for example you are used to using the brand name and then they stop producing it and you shift to the generic, what will be the pros and cons there?
So I can take that one. For the most part, there's no, I wouldn't even say pros and cons, because basically what you're looking at, or to clarify your question, is the medication going to work the same way, right? When you take medications, it's two things that you're looking at. Is it effective? Does it work? And the other one is it safe? So brand medication, generic, basically it's the same thing. They meet the same standards, and because of that, it's safe to take the generic. So yes, I'll take the generic. That's the short answer to it. As far as, there's no con. Let me put it that way. Now, just let me add something little to it. Remember I said in there, like when we made the presentation, that sometimes there are slight differences in the fillers or the inactive ingredients. There are cases where you hear people saying that they are allergic to, like when they take a certain generic, something just doesn't sit right with them. They would say, I've had people talk about, one of the ones we mostly hear is like, is it red dye 40? Like most farmers, like you hear it a lot. And then, just even with food, how people are these days talking about gluten-free and all that stuff. So these are some of the things that every now and then come up. But like I said, the inactive ingredients are not necessarily the same. And the reason is because they have nothing to do with the effectiveness of the medication or its safety. If there's any, like if you feel funny or whatever when you take any particular medication, please talk to the pharmacist. If it turns out that it's an inactive ingredient or whatever in the generic that's making you feel that way, they could most of the time order from a different manufacturer, even though sometimes they don't like to do that. For so many other different reasons. Like Senior KB said, bottom line, money. But like I said, if you feel any different, just let the pharmacist know. Usually they will try to figure out what is causing the problem. But as far as the pros and cons, no, I don't see it as a con. Like there is no real difference in the brand and the generic.
Okay, Leo and dear presenters, this is KS. I have a quick question. I think it's KB who said something about if you've been on certain medication for a while and you think your lifestyle and whatever program that you were on, you feel you've made significant improvement, you can talk to your pharmacist or talk to the doctor to either reduce your dosage or even take you off, if you are on 3 medicines, take you off 2, leave you on only 1, or reduce your dosage from maybe 20 milligrams to 10 or 15. My question is, what if you don't make any such, evaluation to determine whether or not to stay off or to reduce the dosage, and you just keep taking it? Is there any harmful effect?
So yes and no, and again, it depends. I'll give an example. So why this point actually came up was I had somebody yesterday that's on 3 different kinds of blood sugar medications. 2 of them work in a similar manner, and I was wondering why. And I actually saw that yesterday when he came in with his wife, because he had a new prescription. And whilst I was processing it, I kind of noticed that about a month ago, he had received one, in a different class, but worked in a similar manner. And as I looked further, I realized he had been on that consistently for over a year. And then he shows up with this other one, which also would work in a similar manner. And then now he has 3. He doesn't really need the second one. So I asked him about it. Are you supposed to be on all of these medications? And he says, yes. And I said, how is that? He said, well, that's what the doctor gave me. He didn't question it. He didn't ask, and I kind of thought it was a bit unusual. But anyway, those are some of the things that I think you need to ask questions when you go to the doctor's office. You need to ask questions. Now you are able to see your labs. You should be able to, ask and say, this was such and such a figure or such and such a number the last time. Now it looks like it's at this point. What can I do? Do I still need to be on these medications? What can we do? You need to work together with your doctor. Don't be afraid of the prescriber. Don't be scared to ask questions. Ask them questions because they may or may not have noticed. There are many instances where doctors' offices will refill your medications without really looking in your charts to make sure you still need that one medication that they have you on. Now, as to whether it can be harmful to you, yes and no. See, sometimes there's a point to which certain medications, you take, I can give you an example. There's this drug called gabapentin. You can take very high doses, at which point, after a certain point, maybe halfway, it's not gonna give you any benefit. It's probably gonna give you a little bit more of the side effects, but the more doses you take, it's not really gonna do anything to you. It won't help you. So sometimes you'd have medications where you have duplicate medications, you're taking them maybe for your blood pressure. It would keep it at a certain level. Whereas if you take one out, your pressure might go up slightly, maybe by 5 points, to the point where it's not gonna be harmful for you, but at the same time, it's not gonna be as low. Maybe it's being kept around 110, 115. And then they take off the one medication, you go up to 120 or 125, which is still okay. You can do without that one medication. You don't have to be on all three or all two. But these are conversations you have to have with your doctor. These are questions you must ask and say, well, I've done this, I've done that. What else can we do by way of medications to see how we can, take me off certain things, improve my bottom line as to what I'm paying out of pocket. So I hope I answered your question, David.
Oh, absolutely, you did. I mean, just as sometimes with consultation, the doctor will say, okay, you're on 10 milligrams now, given what is going on, maybe you need to go to 20. In the same manner, if you're on 20, there's nothing wrong for him bringing on 10 if you've improved enough, or if they say maybe take it maybe just every other day instead of every day. I think so. All right, I appreciate it, KB.
I have one question. Recently, I believe within the last...
That was saying something, but he was on mute.
Yeah, I think you're on mute, bro.
Yeah, sorry. I was saying that to add a little point to what KB said, he alluded to that in his usual gentleman. I said, these are not changes that you want to make on your own. You definitely want to make these changes in terms of stopping or increasing any doses in consultation with your healthcare providers, including your pharmacists.
Absolutely, yeah.
Recently, I was listening to NPR, and I heard that a doctor was saying that it's not necessary for people to continue taking the medication if the condition has changed or improved. He went on to give examples like the prescription says take this for 7 days, and maybe 3 days later the person feels okay, and he was wondering why people should continue to take the medication beyond the recovery. He added that it's added to sort of diseases people not responding to medications because we are taking too much of them. I don't know if anybody heard that report. He had written a book, and I ordered the book, but I haven't read the book, and I didn't prepare for this Zoom properly, so I didn't make any notes about this. But it's about a week ago, less than 2 weeks ago, that was on NPR. I don't know if anybody else had.
I'll take a stab at it, and then Leo, you can. I'm pretty sure he was talking about an antibiotic. And if that were the case, typically they give you an antibiotic, it's one infection, and they may tell you to take it for a week, 7 days, or for some for 10 days. And sometimes after taking it for a couple of days, you may start feeling better. But there's been studies and tests done to figure out the maximum duration to take it to actually get the effect. Even though you may start feeling better in 3 days, if you stop taking it, whatever was causing the ailment, the bugs that were causing the ailment can come back stronger. And that can also lead to what he was actually trying to say, that you end up with superbugs. So my recommendation always has been that there's a reason why they give you those set guidelines when it comes to antimicrobials or antibiotics as to how long to take it for a particular ailment or a particular suspected bacteria or viral infection. And my recommendation is to try and finish the course of the therapy that he's giving you.
I will try and read the book very quickly and get back to talk to you at some point, but he was very convincing, and the examples were, why take the medication for 7 days or 15 days or 30 days? Why not 3 days or 5 days or 2 days, or that kind of generic across board? Everybody, every adult is taking it for 7 days. Every adult is taking for 15 days. As a layperson, he completely sold the idea to me. You know.
So I just want to, I guess, add to it. So like Hepro already said, when they study these medications before they get the approval and all those things, and especially with the COVID thing around, I guess now a lot of us are getting more familiar with like the drug approval process, like and all the different phases of testing they have to go through. Basically, what they're saying is, so in the case of like antibiotics, you're looking at bacteria infection, which just because you become exposed to the bacteria doesn't mean you're going to have symptoms. It's not just like you have one in there, they multiply and you get to a certain load that starts causing you symptoms. That's when you get so sick, you go and see a doctor. When they give you the medication, those medications have been approved based on the studies that they did. And they realized that if you take it in a certain way at this sustained level, you are able to bring the load down to where it doesn't cause disease or where it doesn't cause symptoms or where it doesn't continue to make you sick. Basically, what he's saying is that in the middle of it, just because you're feeling better, I guess you don't need to keep taking the medication. Unfortunately, you don't even know the level at which, I guess, the bacteria is, but you stop it just because you are feeling better. And like Hepro said, it could come back and it could actually be worse than what you had before. One of the things, unfortunately, with, I guess, blanket advice on like when to stop your medications and stuff like that is, while sometimes you may get away with that, it may not always be the case. And sometimes, it's not everybody who gets that lucky. So my thing is, just stick to, like my personal advice, stick to whatever the doctor prescribed. Like the duration they gave you, even though you are feeling better, you still need it in your system to completely wipe out the bacteria or virus or whatever to the level where it's not going to cause you any symptoms or further disease. I don't know if Senior KB, if you want to add anything to that point, but
incidentally, it was the title of the book is Overkill, and when modern medicine goes too far, and it was authored by Paul A. Offit, MD, OFFIT. MD. I haven't read it. It's in my reader. I'll read it in the next few days. It's Overkill.
So to the point that Hepro and Leo made, the fact of the matter is, like Leo said, it depends on the bacterial load that you have. All right. Now, you might either like overkill, from what the guy is saying from the title of the book, he's trying to kill an ant with a sledgehammer or whatever. But then again, it depends on the viral load. It depends on the individual's ability to fight the infection. For some people, all they need is a little help, which would be maybe 2 or 3 days of the medication. So for some other people, their immune system is not to the point where 3 days will give them that little support that they need to get over that infection. But studies have shown that no matter how weak or how strong you are, 7 days for this medication is what everybody on the balance would need. Some people might need 3 days, some people would need all 7. some people actually even need more and will have to go maybe 10 days.
Right.
You know, so there is no one size fit all really when it comes to, you know, stuff like this. But the evidence is what the practitioner or the prescriber will go by. And if the evidence shows that 7 days works, it might be overkill in some instances, but the evidence says 7 days across board works for everybody or for most people. I will stick with what the evidence says.
So you sound like resources are limited, but if we are able to get our doctors to follow us up closely and test it a few days after they are prescribed, maybe they can kind of calculate this and titrate them for, you need it for 3 days, you're okay, and you 7 days, you're okay, and not that average kind of thing. One personal example is whenever I am giving prednisone and my doctors after surgery and they follow the tapering to the letter, everything goes haywire for me at the end of tapering. I can't be tapered off. And in one case after eye surgery, I continued prednisone for 6 months. Anytime they tried to stop, I couldn't step outside, I couldn't look at the sun, I couldn't do anything. The last surgery I had, I discussed that with the eye ophthalmologist. And instead of prednisone for 1 week, 4 times a day, and the following week, 3 times a day, Dr. Mahmoud took me off after Friday surgery. Wednesday, he took me off prednisone. I had no inflammation and I was okay with it. So that was a case where my body wouldn't take it. And I had a conversation with the doctor, and he, from his experience, he decided if I take you off 4, 5, 6 days after surgery, no infection, no inflammation, you'll be okay. And that worked perfectly for me.
But the doses were not the same doses they were giving you before, right?
No, it was basically put these eye drops in your eyes 4 times a day for 1 week. The second week, reduce it to 3 times a day. Then the following week, reach 2 times a day, and then once a day, and then taper off, stop. And whenever I did that for 3 previous surgeries, it was hell on earth for me. The first time around, they couldn't take me off. Anytime they took me off, I couldn't step out and look at the sun. So the doctor calls, I call her and she says, get back on it right away. And after, on my third, 4th surgery, is when we had the conversation with Dr. Mahmoud. And Friday surgery, I was off the following Wednesday. And nothing happened to my eyes. I healed nicely, and I had no problem with inflammation or anything. I have another question, very quick one. Why is Dr. Fauci not able to tell us that hydroxychloroquine does not work? What does he mean by it is not effective?
So this hydroxychloroquine thing, all right. So I think let's try to see if we can understand a little bit about how this whole hydroxy and chloroquine thing came in. So I think in the SARS, when they had SARS a few years ago, they kind of messed around with it a little bit. It works twofold, if I can remember some of my pharmacology a little bit. It works twofold. It works against viral replication. And then also for, you know, if you have these kind of viruses, the body tries to fight them. And then it gets to a point where your immune system goes into overdrive, what they call a cytokine storm. You know, and that's what can actually lead to multiple organ failure, and then eventually you die. That's what causes a lot of people to crash. Now, hydroxychloroquine is actually used for autoimmune diseases, which is where the body fights against itself. So the school of thought is that it can help, you know, 2 ways. One, help you when you're recovering from COVID with your autoimmune system, kind of like your immune system fighting against the body. And then also in the initial stages or for prophylaxis, help with viral replication. Now, as to whether it works, I don't think there has been enough time to study it. So we don't know. I personally think there's more out there with this whole COVID thing that's going on. There's a lot of unknowns. You know, we are kind of like in territory that we have not been in before. Nobody knows, so everybody throws things out there. In the beginning, they said don't cover your face, and then they said cover your face. Wash your hands. Now nobody really talks about washing your hands anymore. Stay 6 feet apart. It's an evolving thing. So I don't know for sure. All I know is these are the possible ways that hydroxychloroquine can help. As to whether it really helps or not, we don't know, because the evidence is not really there now to actually back it up.
So when he uses a word like it is not effective, what does that mean?
Well, that's another way of saying, in my opinion, that's another way of saying it doesn't work for that purpose. That's another way of saying it.
Yeah.
In my opinion.
Yeah.
And as KB said, Dr. Fauci works or believes in evidence-based medicine, right? And so if the evidence doesn't support that, then to him it's not effective or it doesn't work for that purpose. But
that is the political way of saying it's not. It doesn't work.
It's more of a medical term. So in pharmacy, right, there are two tests that we say a drug has to pass before we can call it a drug. One, it has to be effective. Once again, the word. That is, so if you say it kills this bug, then it should kill that bug.
Yeah.
That's what you call effective. If it doesn't kill it, then it doesn't meet that test. The second test is it has to be safe. So when you take it, it doesn't kill you. If they don't check off those two boxes, then, I mean, there's not much to say about it in terms of it being a drug. So yes, it sounds like he's being coy, but not really. That's the term, like that's the very definition we need, like we use in our world or in our practice. Is it effective? Does it do what it says it's going to do or not?
So when you say it's effective, are you talking about a certain percentage of subjects who responded well to the molecule, to the drug, or are you talking about how many of the bacteria that were killed or destroyed? Is it the number of patients that makes a drug effective, or the bacterial load or the infection load that was destroyed? The efficacy.
Somewhat all of the above. Okay, go ahead.
Okay.
No, see, I can go ahead.
No, I said absolutely what you just said. It is all of the above, because if it can't get rid of the bugs first of all, then it's
it's a no-go.
Yeah, and then if it can only help 10% of the population, then it's also no good. There's a number that they look at. I can't remember the percentage. It's kind of the statistics, but there's a percentage that they look at. And if it's not in that percentage, then I think it's 97%, I think, but I'm not 100% sure, so don't quote me. But there's a number that they look at. And then Leo also brought up a very important point, the safety of the medication.
Yeah.
Now, hydroxychloroquine and chloroquine, like we had in Ghana, they have that safety issue with your eyes, I believe, and then with your heart. Now, if you have COVID, the thinking now is that the less healthy people are the ones that are more susceptible to it, like in terms of getting really sick. So if you are not that strong, chances are you probably have some underlying cardiac issue going on already. And then you load your body up with hydroxychloroquine, you're asking for trouble. There's safety has not been studied to the point where, and nobody wants to stick their legs out. America, the lawsuit is right around the corner. So if he comes out and says it's good, it's effective, it's this and that, without the evidence to support him in case of a lawsuit, he's in trouble. He's not going to do it. That's the other.
And ultimately, every physician is going to weigh the benefit versus the risk of giving that medicine out to their patient.
But they've been giving us hydroxychloroquine forever in Africa.
That was chloroquine actually, and that was. I think that's a less safe option.
Version,
Yeah, than hydroxy. Hydroxy is a little bit different. Yeah, I mean, they have the same base molecule, but a little bit different. So it's safer than the chloroquine that we took for ages, causing people to itch forever.
Right.
Yeah.
And to add to that,
what they were treating was one of the different from what they are trying to treat now.
Yeah.
I think one of the things with this hydroxychloroquine debate, right, especially when I talk to like Africans, especially Ghanaians, What I've noticed is because of our familiarity with chloroquine, I guess a lot of people had this hope that it would be the cure to COVID, and somewhat found it a little disappointing, or that's part of the animosity they have towards Fauci for, I guess, denigrating their favorite chloroquine. One of the things I think we, at least back when we grew up in Ghana or whatever, one of the things we didn't pay a whole lot of attention to was like side effects of medication. You see, they give you the medication, nobody tells you it has these side effects or whatever. And because of that, we tend to think that they are, like, every medication we were given was safe. We also tend to forget that there were so many times that some people just like dropped and died, and nobody, of course we blame the witches and stuff, but nobody took the time to even tell you that maybe it was just an allergic reaction to the drug. Or maybe they had some pre-existing or comorbid conditions that precluded them from using those drugs. And like all kinds of stuff that, like, of course, it's like we flew blind. And because of that, like when we hear certain things about certain medications, we think, we're used to this. We used it when we were kids. What's the big deal? Why are they talking about it's going to give people a heart attack and all those things? If you actually look at the profile of hydroxychloroquine, you're talking about arrhythmias like QT prolongation. That could be a big deal if you get that side effect. If you don't, So these are some of the, I guess, issues surrounding that hydroxychloroquine debate. It's not cut and dry.
Yeah.
It has its issues.
Yeah. I have one last question, and whilst we are talking about Ghana, I'll just squeeze that in and just leave the floor. My last question is that how would patent enforcement of patent laws help with herbal medicinal development in Ghana, probably in Africa? Our grandparents and granduncles and fathers die without telling you what is in that herb that they used to cure whatever they did, simply because they don't want anybody else to know. And it's not their fault, because they have no benefit in sharing with the community. They are not going to get the little chicken or egg or goat that will follow when they give this herb to somebody. How would proper patent enforcement help with drug development, herbal drug development in Ghana, if it would at all?
I'm not sure. I'm not sure how to answer this, but I think if we have the right systems in place, the right systems in place where the right because there's a lot that drug manufacturers go through. It's a process that takes, it takes a while from start to finish, to get that medication out there, to get that patent, actually even to register it and hold the rights to it and make some money. I don't know if the structures, we have the structures, and we can encourage the local people to take advantage of it. I think there's a lot in it. The systems have to be there. The systems have to be perfected. The people, both the end user and the actual, the investigator, the end user being the manufacturer of the herbal product, they all have to trust the system and make the system work. Where I can trust that if I put this application in concerning this medication, nobody's going to sneak it out to somebody else and say, hey, this thing is coming in. That herb that grows behind your window. This guy has found it, it can do this. You can, if you want to be quick, I have the application on my table, bring it quickly. That trust has to be there. And I think that's the reason why the older folks die with the knowledge that they have. They don't want to share it because there's no trust. There's a lot of mistrust because everybody, that if I give it out, I'm not going to make any money. So I'm going to keep it to myself. But in this system here, they have set up structures where, if you put that thing out there, nobody else can come in and claim that they found it before you did. Well, that's a lawsuit, and somebody's going to get in trouble. So I think basically maybe that's what it is. That's what I think, but I don't know for sure.
And KB, I agree.
I think that probably should be a PhD thesis for one of you. That should be a PhD thesis.
Maybe Headbrook, I help my sister. Help me, can't hear you.
I have a question.
Sure.
Yeah, it's my doctor put me on amlodipine for blood pressure, and it was 10 milligrams, and it got it was causing my feet to swell, and so it's very uncomfortable. I've been on it since January. You get slight heart palpitation, and then sometimes you get swollen feet. Now I've spoken to him and told him that I want it changed because I just don't like it. Coupled with the fact that I can't drink red wine, it's worse. So I want to go talk to him. If I'm talking to my pharmacists, are there other ones that are in the same class that can be used, or it's purely a conversation I need to have with my PCP?
I mean, I would say, so amlodipine it's swelling of your feet is classic with amlodipine.
Yeah.
And the drugs in that class actually, but amlodipine is kind of notorious for that. There are other members in that class, well, that work in a similar manner that can actually be considered. You talked about heart palpitations. There's an older drug, but these are conversations you have to actually have with a doctor and then pushing. Well, sometimes they would stick with what they know, because what has worked for them is what they would kind of stick with. And but if you push and you push, sometimes they would kind of reevaluate the therapy and then give you something else. There are other medications like the diltiazem kind of group that work like amlodipine, but also would help with your heart rate, and if like the palpitation that you have, if it's an issue, it can help control that for you. But then again, you still have to have that conversation with him and see what he wants to do. But yes, there are options that can be, it can be switched to. And then also maybe, was it the only one that you were on, or there were others as well? Or we can talk offline if you would be more comfortable with that. But maybe he might consider changing you completely and use a different class of medication as well.
Yeah, actually I was on amlodipine and losartan.
Okay. So yeah, so he can actually take you off that, and then he can either consider doing maybe a diltiazem or even go to a beta blocker, so like a metoprolol kind of thing.
Yeah.
And because that can also help with your heart rate as well.
Yeah.
That we don't have the palpitations. Maybe like a metoprolol and in combination with that losartan should be fine.
Yeah. Yeah, and the reason why I'm asking is only because a lot of it. I mean, I get it. Most of the PCPs want to make sure their lifestyle changes. I exercise, I do all those things. He wants me to change completely to become a vegetarian. He's Iranian, and I struggle a bit with it. That's the reality. But then I just want to make sure that the medication. I mean, if I'm taking medication and it's making my feet swell, then I don't want to be on it. So I want to be part of the conversation, but prior to going to see him, I want to make sure that I've armed myself with at least options or exactly what to tell him. But I'll call you anyway. And whenever I have questions, I normally call you.
Yeah. So perhaps we'll call cry. We can talk some more.
Yeah.
Yes, there's a question. Somebody just texted me a question.
Okay. Please go ahead and read it for us.
So he said that I have a 7-year-old daughter who had a seizure like a few years ago, and she was placed on a medication called Keppra. It was 5 ml. But once in a while, the seizure symptoms seem to come up. So I spoke with the neurologist, and it was increased to 6 ml. But still, once in a while, they still get seizure once in a while. Should I be expecting the neurologist to keep increasing the dose, or what would be your advice as a pharmacist?
Okay. So basically, if every now and then she gets another seizure, usually with seizures, they look at the frequency, because unfortunately, the medications, I mean, as good as they are, don't completely eliminate it. Every now and then you get lucky and it goes away, I mean, permanently. But so most importantly, like with everything we've said, continue to work with the doctor. As far the neurologist, as far as expectations, yes, because obviously she keeps having seizures, it looks like the medication is not as effective as it should be. So they're either going to increase it to a level where it actually reduces the frequency of the seizures, or change it to a completely different medication. Because, like I said, just because she keeps having the seizures means it's not working the way it's supposed to. So there are two options. Either you increase it, you maximize that medication, or you switch to a different one. So unfortunately, yes, I mean, that's what he's looking at. Yeah, I don't know if anybody wants to add anything to it, but.
Yeah, and there's one other thing too with these anti-epileptics. Usually there is a range, I believe, that like like a blood range that is supposed to control the seizure. If it falls below that range, then that is when the seizure might occur. Some things I have to kind of read into it. I'm kind of like ad-libbing right now, but some things would can affect the levels. So maybe they might have to investigate and find out, what triggers it. Maybe, how often do they have blood work done to see what their levels are, and then probably adjust the dosing accordingly. At a certain point, they might probably have, and then like Rita said, once in a while, maybe the seizure will pop up, but then they'd have to investigate, find out why the levels are, why the levels dropped. Do they need to increase the dose? Do they need to add another medication to the regimen?
Good.
It's one of those
Yeah.
things.
So the follow up, let me read what he says here. He said, "Well, let me give you the history." Actually, he's listening. So he said, "Let me give you the history behind this." So my daughter had an abscess in the brain, and a surgery was done with a VP shunt, and so after which she never had any issues. 3 years after the VP shunt was placed, once in a while, her heart races violently. So the neurologist put her on a conducted EEG and realized that some of the electricals did not work well in the abscess region of the brain, hence the periodic seizure. I don't know if this background helps. Thank you.
I mean, that only explains why, because usually if there is irregular brain activity, that's when, seizures happen. When it's kind of like above a certain threshold. So that only explains it, why the seizures are there, first of all. But then the Keppra is there to kind of control that brain activity. And it only does that if you have a certain level in your bloodstream. Right? If you drop below those levels, then it exceeds that threshold and you can have a seizure. You know, so what they actually need, and I'm sure that's what the neurologist is doing. Anytime they go and do blood work, find out what the levels are. If it's below the therapeutic levels, they'll bump up the dose. You know, and it's with seizures, it's kind of like they'll do it for a while till it gets to a point where they hit that sweet spot. You know, where your levels stay the same based on the medications you are taking consistently, and then you just stay there, you're fine. So, and since it's a child, as they grow, it's going to be changing all the time. So they become adults. I don't know if that helps or not, but.
Okay. Purple.
Okay. This is David.
Yeah, it's for somebody. So it wasn't.
Okay, yeah. Like I hope they heard the response.
Yes.
Okay.
So this is David. I have a question about heartburns. What would you guys advise with heartburns? Because I have been prescribed omeprazole for heartburns, and I've been taking it for some time. I think Headcrew knows about it. But what would be the general advice to solve that?
Okay. As far as heartburn, let me quickly jump on that because I personally, deal with it also on a, if I should say, a daily. It's one of the most annoying things that, of course, you could experience. So, I appreciate your frustration or whatever with it. One of the things, though, is get it checked if you haven't already. Because sometimes it's just a symptom of a more serious underlying condition. It could be like a full-blown peptic ulcer or whatever. So my first advice is just make sure you get it checked. And through your wellness checks or whatever, just bring it up with your doctor and then kind of have them evaluate it to see if you need any further test or whatever. The other thing you also want to look at is what actually triggers it. Is it like something that's like constantly bothering you, or there are certain things that trigger it? So for me, I'll use myself as an example. Every time I eat pepperoni pizza, like I'm in trouble afterwards. Rice. So, which I guess is a good thing because I probably should cut back on, how much rice I eat. But anytime I eat rice, I get like severe heartburn to the point where like I actually wake up in the middle of the night with that acid brush, whatever. Like it's crazy. So when I'm going to eat something that I know would trigger, then what I do is I would actually take like omeprazole, what you take, about 30 minutes before I actually eat it. If it's something that I really want to eat so bad, like if, let's say you have a meeting or you want to go hang out with your friends, they're going to have pepperoni pizza, and for a fact it's something that triggers it, then definitely you take it half an hour before you go hang out or whatever, and you're fine with that. Because for me, they checked me and I don't have any peptic ulcer disease. So unfortunately, it's one of those things, like annoying things that I just have to deal with. So it's just lifestyle modification. If you can avoid the food altogether, then go for it. Like I said, because of that, I actually barely eat rice. But when I have to eat it, I see some jollof that I'm really, really excited about. Then I just, just go with it, take my omeprazole, and then 30 minutes later eat my jollof and I'm free. There are certain people that they can just take regular antacids like Tums, and it works. So it's, I guess most importantly, you have to study your patterns. See if it's something that's triggered by the food you eat or it's constantly around, and then go from there. But most importantly, discuss it with your doctor because, like I said, sometimes could be a symptom or sign of something more serious.
Okay.
I don't know if anybody wants to add anything to it.
Thank you. I've checked it with my doctors. I've done both endo and then
okay.
both of them. My mouth and there was nothing. So it's just one of those things. But probably I need to lose my weight a little bit. But what I've been trying to do, because you advised that I should take it early in the morning, 30 minutes before anything goes into me. And that's what I've been doing. But it's like, I have to take this every day. That's my problem with it. But okay, thanks.
So let me ask you though, the days that you, have you ever skipped a dose before?
Yeah, nowadays, I have started skipping days. And if I skip it for 3 days, then it comes back.
Okay.
You see, I can take one today, and maybe I wouldn't take it the next 3 days. Then it will start coming. So then I have to continue.
So there's another because some years back I also had the same issue. I mean, I work late. I'll get home maybe 9, 10, and
Yeah.
that right. You can't, especially when that jollof. You walk here, can snap, and then you wake up 2 o'clock, 3 o'clock in the morning, and your chest is on fire. You know? So, like Leo said, I personally made a conscious effort not to eat carbs after a certain time in the day, because I found out that was what was hurting me.
Okay.
You know, because if I ate anything, maybe kinky, rice, that's like in the evening, late, I have to sit up for at least 3 or 4 hours. Because if I go lay down, I guarantee you I'll wake up a few hours later with my chest on fire.
Yeah.
The one thing that helped me, you know, in between was I would use Pepsi Complete.
Mm.
You know, I found that helped a lot. So if I had that, you know, acid brush, I'll just, you know, pop one, give myself like 15, 20 minutes. It calms it down, and then I'm good to go. But, you know, just watch what you eat. When you eat what you eat, watch what triggers it. You know, apart from the carbs, maybe alcohol, smoking, those things, the pepperoni. Pizza is like, you know, when Reda was speaking, I was smiling because I was like, this thing will make your chest go, you know, it will burn. No two ways about it. Pizza is so they taste good, but you pay the price. You know, just keep a bottle of Pepsi Complete handy. And then the other thing I found out also was that with omeprazole, either early in the morning or, like Leo said, before your largest meal of the day, because the larger the meal size, the greater the likelihood of that happening. So maybe half an hour before, you know you're going to eat that banku and tilapia, you pop that pill like 30 minutes before while the tilapia is cooking. Just take your and then just use it to wait. You know, that way you face your tilapia, you face your banku, you are good to go.
Okay.
Try that and see what happens. Then probably get a bottle of Pepsi Complete, you know, hand. Yeah, that actually does help a lot too. So
okay. Thank you very much.
Definitely watching what you eat and the time you eat. I know.
Yeah.
We all deal with it from time to time.
Yeah, I personally have these issues, but I've decided when I go to any party, I don't eat, and it doesn't matter what people say. Some people even think I'm a chief from the village, so I don't eat outside my house. But it's just because I know what I'm going to go through. So it's just sort of, I've really stayed determined not to do that, and I don't really do anything to impress anybody anyway. So.
And I'm sure you don't have that issue anymore, right?
I mean, I don't eat, so it doesn't happen. Yes.
Yeah.
Or sometimes I'll even take the food that I'm offered at the parties or the functions, but I'll take it home and eat the following morning. But I know after a certain time, 8 or 9, if I eat, I'm in trouble, and I don't want to do that.
There you go.
Okay, I'm glad I'm not the only one facing this.
Yeah, so quickly, someone actually asked the question, like, what's the name of the medication that we recommended? So, like Senior KB said, there are multiple options. So you have Tums, you have Pepsi Complete, you have omeprazole. And I mean, which one is the best one? It all depends on you. Personally, I take omeprazole. The brand name is Prilosec, but it's an old drug. They have the generic out. I mean, Walmart has it, Target, and it's over the counter, so you can stop by anytime and pick it up. I work at Costco. We have them in like huge boxes, so I just grab one every now and then and bring it home. So that's my personal favorite. I just take it 30 minutes before I go eat my pizza if I have to, or rice, whatever it is, banku and tilapia. So pop it 30 minutes before that. Like Senior KB said, while your tilapia is sizzling. By the time it's ready, I'm good to go. But the name is Prilosec. The other one that Senior KB talked about, Pepsid Complete.
Is that the same as Prilosec OTC?
Yes.
What does it do? Like heartburns?
So, okay, that's what we call a proton pump inhibitor. You know, when you eat, your stomach actually secretes acid that helps you digest the food. Basically, the pumps that release that acid. So what Prilosec does, it shuts down the pump so that the acid isn't released or like released as much for it to give you the heartburn. Because usually it's the excess or whatever when it climbs up your goes past your esophagus, your that valve that's supposed to prevent it from coming back up into your throat. When it bypasses it, that's when you feel your heart or your chest on fire. So if you are one of the strategies, they have the antacids like Tums, which when the acid is already released, you take it, it neutralizes it, and that's supposed to give you relief. Then you have the Pepsid Complete, which we call, I mean, just a fancy word, angiotensin receptor. How do you call it? Someone, give me the H2R. It's the H2 receptor antagonist. So basically, yeah, I was actually talking about the Pepsid Complete, the H2RAs. So basically, it blocks. It's all the release of the acid that causes the discomfort. Okay, so if you are able to either neutralize it or prevent the acid from being released, then you solve the problem. So I don't know if I answered your question, but basically that's what you're targeting. So those three medications, Pepsid Complete, if that works for you, that's perfect. Get it, and if you remember it, take it before you eat the food. Or if you forget and you already started, like in the middle of the banku, you feel your heart is, your chest is about to catch on fire. You can pop it anytime, and basically you're good to go. And like I said, Prilosec, you go to Costco, they have the big boxes. It's super cheap, and you can check it. But if lifestyle modification, like Senior KS said, he has decided not to eat at parties or whatever. If you have that willpower and you can resist eating benku and tilapia or pepperoni pizza, then you're good to go. Or whatever triggers your particular heartburn, I guess. Let me put it that way. If you can check for your triggers, that makes a lot of difference. Because, you know, if you can modify your lifestyle so you don't have to pop a pill, that's usually the best route. So,
but definitely you don't want to eat and go straight to bed.
Yeah,
that's the more reason why you want to cut off your dinner or supper at a certain time. And we're all guilty of it. We work, get home at 10, and you sit before the fufu and abenkwa, and it's so delicious you don't even know when to stop. So
there's a question from Facebook, which is a concern for Santa 96 year group members because they are also turning into their 40s. So let me go ahead and ask. It says, what's the best medication to recommend for men 40 years and older? I observed that since I turned 40, my manhood doesn't stand up in the morning again. Is it normal? I've also observed that I'm not able to keep my erection standing for a while. Is it an age factor? Any recommendation? I still exercise and eat healthy, but as a pharmacist, what's your best drug to recommend?
my recommendation would be get it checked out. One, as you said yourself, maybe a factor of age. It could be that you are too tired at times. It also could be an underlying issue for some ailment, for instance, diabetes. That could be one of the signs, first signs that you developing or have developed diabetes. So if it's such to the point that it's causing concern, then as I stated in my presentation, get it checked out, get evaluated. And once you get evaluated, fortunately these days there are medications out there that can help with ED, as is commonly referred to. So definitely get it checked out. But to your question, yeah, there are medications like Viagra, Cialis, and some others that will help with that. But you want to get it evaluated. At least that would be my opinion, because it could be an underlying issue for some bigger issue. Okay. Anything to add, Leo or Katie?
Let me ask something, because this question came up on one of the Ghana shows that I was watching, and some guy asked a similar question to this, but with what he said was that he was having all these issues, but he had a side chick as well, right? So anytime he went to the side chick, that wasn't happening. But when he came home, he was having this same thing. Is there something psychological to this, or
he has real issues? I'm kidding.
I mean, I think in a way there probably is, because I mean, if you think about it, ability to get excited depends on what the eye sees, affects the brain, and then the brain controls the rest of the body functions. There's a reason why you would see, let's say, a plate of jollof, and even though you have already eaten, you feel hungry and want to eat. And then there's a reason why at that same moment you see a plate of rice and stew and you have zero interest for it. Not to kind of like equate, your spouse with your side chick or whatever. But sometimes what does happen is the whole familiarity, concept can affect you in a certain kind of way. You're familiar with, so your interest, because maybe whoever the wife is, whoever your spouse is, your interest is not to the point where you want to, do certain things. It will affect your performance. That's for sure. And then also age always is a factor as you grow older, because I think there's this conventional wisdom out there that I'm trying to rack my brains here, that after the age 40, I think 10 to 40% of men will experience some form of erectile dysfunction. And then age 50 to 60, 50%, 60 to 70, 70%, so it goes up higher as you grow older. I mean, what you could do when you were 25, I mean, let's be real, you cannot do it at the age of 40. I mean, just look at it this way. Physically, maybe when you were 25, you could kneel and then stand up in like 2 seconds. At the age of 40, you can't do that. You might probably need to hold on to something to pull yourself up. No matter how fit you are, or even let's go back to our days on the hill when we used to do 45 on the lockers and stuff like that. I know right now, ask people to do 40, they can't do it. It is what it is. The body, as you age, does not have the capability to do certain things anymore. If you try to push it, you probably cause yourself more harm. And other things also come in, your stress levels, anxiety, like Hedru said, your health, because diabetes is classic for that, even blood pressure. And then alcohol use also can affect you when it comes to that. Those are little things that can affect you. But at the age of 40, you don't try to be a hero. Just take it. You cannot compete with a 25-year-old kid. You simply cannot. Don't be a hero. Just take it.
In hard math, it's called DYDX.
I like
that. In hard math, it's called DYDX is equal to 0. You are the turning point.
That's right. That's right.
So try some lifestyle modification, work out, spice it up, go jogging with your spouse, go walking, invite her when you're working out, try all those things before you resort to medication. But definitely do get checked out if you persist.
Yeah.
Scenario, I think about a year or two ago, you guys were talking about what was it called? This blood clot medication that in the past was recommended for men to take once in a day, aspirin. And then I think, if I remember correctly, Senior Sister posted something about it being wrong or the doctors finding something else with that. So what do you guys think about men taking aspirin tablets once in a day? Is that still the norm, or is it causing something else that there's been a dispute about the potency of that we should stop doing it?
Baby aspirin, I remember. Baby
aspirin.
Yeah.
Again, as stated earlier on, medical, most medical practice follows the evidence, right? So the current evidence is that for people who having had an event, like a cardiac event, heart attack, or stroke, or anything, taking the baby aspirin once a day actually does more harm than good with regard to the side effect of GI bleed. So the current practice is moving away from the advice to take it once a day. But for people who have had an event, who have had a heart attack or a stroke or something, taking it does help. So again, weighing the benefit versus the risk in this case, I used to take aspirin once a day myself. I started on my own. Now what I do is, I take it every 3 days or so, because aspirin does have a long half-life. But even that, I take the coated aspirin, enteric-coated, so that at least it's a little softer on your tummy. But that is the evidence doesn't support it. It's used by people who don't have issues, but again, these evidence keep changing, so you just follow it. So if your question was whether you should take it or not, that is something you may want to discuss with your physician. I take it because I have other comorbidity, so I believe that, from what I know, taking it may help me. But again, I don't take it daily. I take it at least once or twice a week, on my own.
Okay. So, Prof, I hope that answers your question. Because like he said, it used to be the blanket advice that after 40 or whatever, just take a baby aspirin every day. And then we had that study that Sasta posted on the platform. Basically, they found that it wasn't necessarily the case. And because of that, they moved away from that practice. Just to sum up everything that Hedru has said. So most importantly, discuss it with your doctor. I know it sounds like we're saying the same thing, discuss with your doctor with almost everything. But the reason why we say that usually is because how you have multiple specialists treating one person for different things. Unless you have everything in front of you, it's actually hard to give a blanket advice that do this or do that. Unfortunately, our bodies react differently to different medications and to different things. And just because one medication works for somebody doesn't mean it might necessarily work for you. Reason being that you may have certain conditions that I don't have, or I may have something that you don't have, and all that stuff. So most importantly, consult with your physician when it comes to taking stuff like aspirin, because like Hedru said, one of the side effects is GI bleed. That is it can actually cause you to bleed in your gut, your intestines, whatever. just to even add to the heartburn thing, I mean, you don't want to add that to your wahala, for a lack of a better word. So, yes, it used to be the conventional wisdom, like everybody should take that. Now they are pretty much, that's not the recommendation anymore. If you've had an event, yes. But usually if you've had a cardiac event, most of the time they put you on other medications anyway, like Plavix, or these days they have Eliquis and all kinds of other stuff. So most importantly, especially when it comes to anticoagulation, definitely follow your doctor's advice. I think that's the most important thing.
And the bottom line is your doctor will have your whole picture, right? Your total health picture. So he'll be able to make a better, well-informed recommendation than somebody who's just getting a snapshot in time. So.
Okay. So, any more questions before we wrap this up?
Okay. Last question. Sorry, I came in late, so maybe you guys may have discussed this. Our president recommended us that we could use Clorox and see, right? Why are you laughing? My president recommended that we could use Clorox and other stuff for this coronavirus thing. How is that research coming along?
You have to take it up with him and his right-hand man on the Aoba platform. There is no research.
Okay. I have a general question. So, in terms of advice for birth control, vasectomy, condoms, and stuff like that, what would you recommend? Because it seems some people are scared of vasectomy. But what would you guys recommend to us all?
Okay, who wants to take that question? Because that's not an option.
Yeah, married.
That's not an acceptable option.
That's a tough question, but again, you know your particular situation and why you want to choose a method. I personally don't like cotton, so V's out for me. But then there are so many other options, including your partner, has options too. So again, it's something you want to discuss with your partner and figure out which one works best for the two of you to do. But personally, again, one size doesn't fit all. So I can't really make a recommendation as to one or other. I can tell you what I would do, and that is definitely vasectomy won't be one for me. But again, like you said, there are condoms, there are birth control, and then there are condoms both for men, and there are barrier methods, which is condom is one of both for men and female. And also, again, when it comes to surgical procedures, there's a vasectomy for men, and there are other procedures for women too. So again, you want to discuss it with your partner and pick the best option for you. That would be my advice. I would let my esteemed colleagues chime in if they have anything different to add.
I mean, truthfully, no birth control is 100%. You know that. So whether I use birth control or not, there's a chance you're taking. It's just that if you know you really don't want that baby, then abstinence. Just watch Trump on TV. That's all. that will let you sleep early.
So, as a pharmacist, I don't know what the recommendation is. I can only give you the textbook answers. As a friend and brother, I look at it like defusing a bomb. Like you watch a movie, I feel like they might disconnect the wrong wire and it will blow us all up. I don't do that cutting either. So, yeah. But, yeah.
So, also, I have a question. So, still on this corona business. So, I've heard few individuals suggested that the cases in Africa, particularly in abject poverty regions in Africa, the cases are low because of the lifestyle that people tend to walk a lot. People tend to organic food. People tend to walk a certain miles a day. They don't eat processed food and all that. And so for that reason, their body, they have a very stronger immune system. And for that reason, that is why most of the cases in Africa, particularly in these poverty range countries, have very low cases. I know this is not a pharmaceutical question, but from your experience, what do you think? Do you think it falls in that bracket, or is just a myth?
Okay. So, to be honest with you, I think the answer is we don't know. Like the thing with this coronavirus is, I mean, it's been around for 6-8 months now, but there's still a lot that honestly we don't know. So you keep hearing about different theories or explanations for different things, and then every now and then they change it. It's like a moving target right now. So I don't know, but I agree with you. Like for whatever reason in Africa or in some of these so-called third world countries, it hasn't been as bad, or at least the death toll, because even if you think it's because of the lack of testing or whatever, that's the reason why you don't get the actual figures. I mean, they don't have a lot of people dropping dead, like unusually, like what's happening here, like before the pandemic hit. So obviously there's something that's happening there that's making it better, or I guess making the, I don't know the answer to that, to be honest with you. I don't know if anybody knows. But hopefully we'll get to learn it soon. But whatever they're doing that's keeping them safe, I guess I would say they just keep it up.
Brazil
I
is
don't know too
different.
much about it because I think South Africa had a lot of cases though of all African countries. They had a lot. And even besides South Africa, if you look at a country like Iran, Iran is not a first world country, and I think they had the most cases in that part of the world. So it's hard to tell. I don't like Leo is saying, I don't know. I think there's a lot of unknowns. It could be the strain that shows up in that part of the world. It could be that a lot of people are asymptomatic, so maybe testing is not that aggressive. It could be that maybe our genetic makeup in that part of the world is such that we're able to withstand the initial onslaughts and all that stuff. So we don't know, but I'm pretty sure maybe in the next year or two, as studies are done, as more research is done into this thing, some of these questions will be answered. But for right now, the assumption, or because I've had quite a few people say, well, I'm African or I'm Black, so Corona can't touch me. I'm like, please look at the statistics in the United States. In the Black community, how many of them have been affected? Or if you talk about poverty, look at Iran, or even go to South Africa. There are spots that have, you would think that should not, but they have it. It just so happens that this is a country of 320 million people, or 330 or whatever it is. So if you look at it in terms of percentages, though, it's still not that much compared to some parts of the world. Like Brazil, I think it's out of control now. And then either Venezuela or some of the South American countries, also it's kind of like out of control. It's just that the reporting is not loud, so we can't really hear much. But I have a friend that lived in Chile. He came back here. He's been here since April, and he was telling me just a few days ago that in Chile now it's just total chaos. You know, so it's we don't know, I guess, but we'll find out soon.
And to play the devil's advocate in our part of the world, sub-Saharan Africa, also, could it be good old underreporting?
Yeah.
You know, how many autopsies are done when somebody is deceased? So, you know, so time will tell, as with everything.
Yeah.
Great. I have a follow-up. I have a follow-up question though, and so in spite of all the medication being tested, why is it that the world has been silent on herbal medicine? In fact, the World Health Organization on its website actually, you know, in terms of research and development, only allocated 2% of its annual budget to support research into herbal medication. Yesterday, I was having a conversation with my wife, and I told my wife, I said, well, when we were young, if you get sick, the hospital is the last option when everything is unable to work for you. Our parents will just get some some pineapple and some neem tree and some concoction, and by the time you say Jack, you are active, and you know. So I'm kind of wondering why the World Health Organization is not even interested in funding research in herbal medication. We saw that the Tanzania government came out with some sort of a study. I don't know if in Gucci Institute, I don't know what they did, but suddenly that idea of herbal medication issue has gone silent. I mean, from your perspective, I know all of you are practicing orthodox pharmacists, but pharmaceutical stuff. But what recommendation, if you have any, to give in terms of the use of herbal medication?
I mean, the truth of the matter is, or I think that every disease state that we have, there's a cure out there in a jungle somewhere. You know, now to find that cure is a challenge. Medicine has moved on to the point where synthetic material is now used more, you know, because of reproducibility, if that is a word, and then sometimes tend to be more reliable because you can take out certain things and add certain things to it. Natural products will tend to have or tend to elicit more side effects in us than synthetic products do. That's just the crux of the matter. Now, the other thing that we need to look at also to consider is, and I think I mentioned this earlier, do we have the structures? Because for an organization like the WHO, you know, for them to throw money at anything, they expect a certain level of accountability. Now, if you don't have the structures in place to be able to account for every dollar that they give, they're going to give you the minimum amount of money that they can do away with. And if that accountability does not come, they don't feel, it wouldn't bother them too much. Now, you and I know that in our part of the world, the structures are not there, or even if they are there, they are not strong enough where you can actually account for every penny or every dime. You know, somebody can come up with something. I mean, think about it. Back in the day, people would make fake penicillin and be selling. You know, now what is the likelihood of you selling fake penicillin in the United States? It's slim or zero. You just can't do it because the structure that they have in place eliminates bad behavior. You know, but in our part of the world, unfortunately, we don't really have those structures. So it's hard to throw money at a problem looking for a solution where you cannot account for the money. Because what is going to happen is you throw $100 million there into research, and chances are you'd have some good people. There are good people out there that are doing, you know, some good work, but they tend to be in the minority, and there are others that will take advantage and try to make a living out of doing nothing. So until we can prove that we have the structures available, I doubt that they would actually be willing to throw more funding at at whatever research processes that we have. Because before you get funding for any NGO, I believe you need to show that you can do the work. And I don't think we have the structures, I mean, to encourage them to help us and give us the money. We just don't have it. At this time we don't. And so what we would have to do in our part of the world is for our governments to actually make sure they start from scratch, put structures in place to help the people that are in that line stop looking at the donor community, because there's so much that they will do for us. We would actually have to do some of these things ourselves. And then as we produce results, then they will be more willing to give us the money. But as it is right now, I don't think so. Yeah.
So basically, we have to put our money where our mouth is.
Absolutely.
And put the systems in place. But the need is there. The need is there. Those of us who have had the opportunity to experience these herbal medicinals whilst growing up know that there is some truth there. But has it been researched? The need for the research is there. And R&D costs money. Research and development costs money, and it's time. And when you're investing in that arena, the bottom line is at least you want to recoup your investment. And if where is not, you're not sure about the reproducibility and also the safe and effectiveness of what is being done, because there is no what is the word I'm looking for? So, and you agree that some of these things are not documented because my grandfather or grandmother passed it down to me. If I'm lucky, my kids are lucky, I pass it on to one of them. Until we start documenting, at least as a start, documenting these things and showing collecting the evidence, then you can go to them and say, we have this evidence. And we've put so much money into it ourselves as a government of Ghana or government of which other country. So, come to the table and help move this forward. So as KB said, until we do that, people are going to be hesitant to throw money in there.
Yeah, just to add to that, I think one of the things, you remember Madagascar came up with this concoction that they were marketing, and some people were offended because I guess the WHO didn't jump on board and all kinds of stuff. What I say is, if you look at science, right, I think one of the foundations or bedrocks of science is proof. Like, if you say something works, you have to be able to prove it. Unfortunately, I think that's sometimes where we fall short. So, like Head Pro was saying, we don't document stuff. Yes, we have a fair idea that some of these herbal things work. We all grew up using some of them. We know enough to know, hey, if you have a cold or a slight cough, you can use ginger and all kinds of stuff. But the thing is, how much of what do you need to make you well? If we are able to document it very well, and we can replicate it and prove to people that this is what heals this particular disease or whatever, I believe even the world will come flocking to it. Because, who doesn't want a solution, or who doesn't want healing or recovery or whatever? You know what I mean? So I think back to what Senior KB was saying, we have to build the structures in place that will demand some of these answers, so that we're not just saying, hey, my grandfather did this, or my uncle knows this, whatever. It has to be, we should be able to document it, so that somebody else, if I'm doing this in Kumasi, somebody in Accra should be able to replicate the same thing and get the same results. That is science. That's when you get people to pour their money into that kind of research. If not, we will just keep coming up with all these concoctions, and then somebody will say, oh, it works. But ask yourself, are you going to try it yourself if nobody can prove it to you that it's actually effective and it's not going to kill you when you use it? So these are some of the things I think we should probably think about. And so yeah, but that was a great question, Popo. All right. So do we have any more questions though?
I think somebody put something there saying, don't we have an institute in Ashanti, Mampong, etc.? I mean, I think there's Noguchi. I'm not sure what else there is, but having an institution alone doesn't quite do everything for you. I think you have to have more than that. You have to have a process where I come up and say, hey, if you have malaria and you do neem, you do the neem plants, you take so much based on your age, based on this, based on that. No matter who you are, it's gonna work for you. And I can prove it, like Leo said, and the results are reproducible everywhere. That is where it begins to gain traction. But a lot of these things, I mean, we have the institutions, we have Noguchi, they have the things that they do, but I'm not sure it's at a point or at a level where it is where, like how we have in terms of R&D, in terms of research and development, where somebody goes to work every day and that's his job from the beginning to the end. He stays in the lab 12, 14 hours a day working on that one molecule, to perfect it, to have a whole set of data to present somewhere and to get funding, to get people interested in what he's doing and to give him the money and say, keep pushing. Because there's a lot of money out there. And there's a lot of money that goes into research, like into cancer research and all of that stuff. But before they will give you the money, they want to see data, and the data has to be reproducible, it has to be convincing. And for them to know that you are going somewhere with this. If not, they will not give you the money. They will not give you the money at all. Leo, I think you're on mute. We can't hear you.
So I think we've gone way past the time that we actually set for ourselves. But regardless, I think it's been an interesting discussion. It's been very, fulfilling, fruitful, and I think very beneficial. I mean, the questions I think were great, and I hope that to the extent that you had a question, I hope it was answered to your satisfaction. But like I said at the beginning of the presentation, please feel free to reach out to any of us. I know there are some questions that are maybe so personal or private that you couldn't just put out there on a platform like this. So please feel free to reach out to any of us. That's part of the reason why we have this brotherhood or association. And to the extent that we can, we'll offer all the help or advice or counsel or whatever that you need. And if we don't know, we'll point you in the right direction. One great thing about at these school boys is we have enough experts in so many different fields that if one person can help you, there's definitely people who can help, or point you in the right direction. So in the absence of any question, I just want to take this opportunity to thank everybody who took the time to join us on this call, to log in and to spend time with us this Friday evening. I know there are stuff that you could be doing, hanging out with your families and things like that. But these are some of the things that, go a long way to help each of us, better our lives, improve our health and that of our families. So thank you very much to everybody for tuning in. Thank you so much, Senior KB, for on short notice, putting this together, and it was an awesome presentation. And Head Pro, thank you so much as well for, I know you had so many things going on, but you took the time to also join and also present on this important topic. So very grateful to everybody for contributing. And of course, most importantly, Pro for providing us the platform to be able to meet and share ideas and have these important discussions. So thank you all very much, and see you soon on another call. If there is anything else anybody want, like any announcement, Head Pro, if we don't have anything, then we'll just bring the discussion to a close.
Thank you all very much. Thank you.
Thank you very much, Kofi, Leo, KB. Thank you so much.
All right.
Thank you.
All right.
My brother Kachaba.
Yes.
And
That's
Kofi.
it. That's it.
Thank you for your time.
I will wait. Okay, or I can call you. I can call you if that is preferable. I can call you.
Yeah, Kofi, let's talk back door.
Okay. Thank you. Bye bye. Have a blessed weekend, everyone.
Bye. Have a good night.